Our next speaker is Professor Johanna Westbrook. Johanna will speak to us about the collaborative research project with Sydney Children's Hospitals Network and eHealth New South Wales and share results from the study assessing the effectiveness of eMM to improve medication safety. Now, I have to say up front, I am actually a Johanna Westbrook fan. I've seen her present in most continents around the world, and I've always been very impressed. She presented very recently at my conference in Information Technology Across Care in Aged Care, and her work spans the whole gamut of the space. She's a director for the Centre of Health Systems and Safety Research at the Australian Institute of Health Innovation at Macquarie University, although I do remember her from New South Wales University days as well. She's internationally recognised for her research evaluating the effects of information and communication technology in healthcare, which have led to significant advances to our understandings of how clinical information systems deliver, or more importantly, fail to deliver, expected benefits. Her highly applied research has supported translation of this evidence into policy, practice and IT system design changes. In 2019, she received the Elizabeth Blackburn Investigator Award in Health Services Research from the NHMRC, and in 2020 she was appointed the co-director of the Safety, Quality and Informatics Leadership Program by the Harvard Medical School. Please welcome Professor Johanna Westbrook.
Is that working? Oh, yes, it is. Okay. Look, thank you very much for that warm introduction, George. And also thank you to the Secretary for that really, that's a weird sound. Is it sound all right? For that great presentation. And I think starting with the personal experience of having made an error is really powerful. So today in this presentation, I'd like to do three things. I'd like to first of all tell you a little bit more about the Centre for Health Systems and Safety Research at the Institute. We call it CHASER for short. Then I'd like to give you a bit of a roadmap of where we're going to take you today on this journey of discovery, and to outline the sort of elements of the program of research that we've been undertaking so you can see where it all fits together. And then finally, what I'd like to do is give you the first set of results, which the Secretary foreshadowed, which was about answering one of our key questions: does the introduction of electronic medication management systems reduce prescribing errors in children? So let me start by telling you a little bit more about our centre. So as Jeffrey outlined, the Institute is very big and we have many centres and we work really collaboratively together across a number of projects. But each of the centres also have their area of expertise and speciality. And for us, CHASER is very focused on applied research, investigating a range of aspects around patient safety, and particularly to look at how information technology can support improved care delivery, improvement in safety and quality of care. I'm very privileged to have a fantastic team behind me. They're very multidisciplinary, from informatics, psychology, pharmacists. We've got the whole it's a microcosm of the health system working together, because you need that expertise really to tackle these patient safety questions. I wanted to highlight we have 5 streams of research, and these are the brilliant people that lead each of those streams. So Associate Professor Reema Harrison, who leads our healthcare engagement and workplace behaviour. So Reema does a lot of work about how do we get clinicians more engaged and hear from them, and also how can we support more vulnerable groups in the health sector to have their voice heard. Associate Professor Ling Lee leads our Health Analytics and Patient Safety Group. Across all the research we do, we have large data sets, and we rely upon Ling's team to really tackle all that data, undertake the analyses, and also she's leading some really fantastic work in sepsis and decision support related to sepsis. Professor Andrew Giorgio leads our Diagnostic Informatics team, and they are really tackling the issue of we have masses of diagnostic information about test results, imaging results, But we have major problems often in ensuring that test results actually get looked at and that data gets integrated into decision making. So how can technology and different work practices support that process? Dr. Naz Wabi, who's heading up our aged care evaluation and research team, we have all heard across the community the major challenges facing the aged care sector. And we have a number of projects which are working with aged care providers and policymakers to determine how we can better use the data that they have available to them to monitor quality of care. And finally, Dr. Magda Raban, who is heading up our medication safety and electronic decision support stream. You're going to be hearing a lot about the research from that stream today, and you can see that there'd be lots of overlap between the aged care and medication safety streams. So please seek them out. You've got some photos of them. Many of them are here today. I think the other thing that I'd like to emphasise is that with our research, we often undertake very large-scale evaluations, but these are of dynamic interventions. It's not something like a drug that stays relatively stable. When you're evaluating large-scale clinical information systems or organisational culture change programs, there are different research challenges. And part of the excitement and creative part of our work is to work with our partners to come up with the most rigorous approaches to analyse and evaluate those interventions, but also acknowledge the real-world challenges where doing this as healthcare is often being delivered as well. So partnership is just front and centre of all the work we do. And this just gives you a taste of our current NHMRC partnership grants underway, so you get a bit of a feel of some of the projects we're undertaking. And if I just highlight the first one there, which is just kicking off this year, which is to establish a national aged care medication roundtable. And that's going to be very exciting. But all these projects are about not just waiting till the end of the 5 years of the grant to tell you what the results are, but to feed that results back to people as we go along. So that takes us to where we are today, and this was the original partnership grant where we were looking to work with Sydney Children's Hospital and eHealth New South Wales to evaluate how eHealth systems can improve safety and quality. Now, I want to take you on a journey and to tell you where we're going to take you. I've just recently come back from a holiday walking across Hadrian's Wall, so I couldn't resist this. And this is what we're going to do today. You're going to hear about new evidence about medication safety, interventions and whether they work and why, and perhaps why they don't always work, and also about consumers' views about medication safety and their priorities. We want to give you some practical advice so you go away with strategies that you can think about implementing in your own organisation about how you might set about optimising your eMM systems. We also want to challenge you and perhaps present you with some new data about some traditional medication safety practices that we use, such as double checking, and maybe rethink how we use or do things with these strategies in the future. I hope that by the end of the day you really appreciate the value there is in collaborating across with clinicians, researchers, policymakers, and the value of high-level rigorous applied research. And finally, we're going to be launching the Health Innovation Series, and we're really excited about this. So these are short pieces of evidence that are actionable and that you can take away tips for how to implement and improve your systems, but also how users might improve the use of their systems. So, the context. Our speakers this morning have highlighted to you that medication safety is currently the WHO Global Patient Safety Challenge. They set this challenge that they wanted to reduce severe avoidable harm from medications by 50% over 5 years. An incredibly ambitious target and quite difficult given that we have quite little information about how much harm is associated with medication errors. It's costly. Medication error is the single most cause of preventable harm. But we do have some great information and evidence building that information technology is incredibly useful to improve medication safety. And around the world, if you look at the business cases for why health systems should invest in clinical information systems, the reduction of adverse drug events is front and centre of those business cases. So we started this work in eMM over a decade ago, which is pretty scary, when our first Sydney teaching hospital started to roll out eMM. And we had 2 teaching hospitals, and we ran a control before and after study to see whether prescribing errors changed. And we found in that reasonably small study that prescribing errors declined by 50% relative to the control wards who did not receive this system at that time. We also undertook a small cost effectiveness study, and these are actually incredibly rarely done around the world, to look at what are the costs that you might release as a result of reducing adverse drug events. And in one hospital, it's estimated that there were not savings, but monies released in the order of about 3.5 million. We rarely save money in the health system, we just increase capacity to treat more patients. And a recent systematic review we've just done where we brought the evidence together around the world about whether eMM systems are effective, we found that 9 out of 10 studies showed a reduction. Okay, but what about paediatric patients? And many of you here will be aware that prescribing for kids is particularly challenging. And it's very interesting that when we started this work, there were very few studies to look at the introduction of eMM in paediatric hospitals. There had also been concerns raised that when you just take an adult system and you place it in a children's hospital with a bit of tinkering, that it actually, in some cases, may make things less safe than before. So we embarked on this research really to answer the question, is eMM the solution for paediatrics? This was the state of play at the beginning of the study. So we found 9 studies internationally. Only 4 of them had looked at the effect of eMM across multiple general paediatric wards, and only 3 of them were reasonable quality. And what they found was a very small study by Barber in the UK showed that after 6 months there was an increase in errors. Walsh in the US showed that after 9 months there was no change. And Holsworth found 15 months later a significant reduction in medication errors. But you can also see that these studies were done between 2005 and 2008, so technology has moved on substantially, but the results were pretty equivocal. I'd also at this point like to thank my team for lending me pictures of their children to add to my slides, and there is a competition to be able to match the team member with their children, so keep a close eye out. So we started by knowing that there was very little evidence, no hospital-wide paediatric studies in the last decade, there'd been no Australian studies, and no studies that ever used a control group. So this is what we set out to do, to assess the effectiveness of eMM to reduce medication errors, both prescribing and administration, to look at harm and whether harm actually changed as well, and to conduct a cost-effectiveness study. Now, I'm going to outline our program of work to you so you'll know where all the pieces fit. And you can see that it's run over from 2016 to 2022. So we started by undertaking a stepped wedge cluster randomised control trial. And this allowed us to answer the question, do medication errors change in the first 70 days that clinicians use the system? We also wanted to talk to clinicians. So we did over 120 interviews with clinicians as the system was rolled out. So we talked to them after their first week of using the system, their third week of using the system, 6 weeks after using the system, and 26 weeks, to hear what they had to say about how was it integrating into their work. Did they think it was improving safety and quality? When we identified errors, we also set up harm panels who would review cases to determine whether that error led to actual patient harm. And we've got many dedicated members of those harm panels here, Les White, Madeline Gazarian, and many other members of the steering committee who spent many hours wading through cases to do that. We were worried that 70 days may not be long enough to see an effect. So we also took a sample 1 year after the system had been in place to see whether prescribing errors had changed. And because we can't help ourselves as researchers, we've now just finished the data collection 4 years after eMM. And we can't tell you the results of that today, but that will be coming. Now, we had a second hospital site. Their implementation was slightly delayed. So the second site, Sydney Children's Hospital at Randwick, we did a before and after study 8 months after they had had the system in place. A critical question many of you will be aware of is, do eMM systems actually introduce new types of errors? And our own previous research in adult hospitals, as well as studies from overseas, have shown that they do. So what we did was that we reviewed all the errors that occurred after the system had been in place to identify those that may have been facilitated by the system and the types of features which may have led to that. All the time, we were feeding these results back to the site, and the steering committee was absolutely fantastic in being very responsive to hearing the data and working through it. Finally, consumer experience. So we started this part of the process by doing a survey of patients to find out what types of costs did they incur when their children were in hospital. Often when we do a cost effectiveness study, we only think about the cost to the health system, but families incur a lot of costs: parking, childcare for the other kids, time off work. And so we sent a team of researchers in to find out from parents what they had experienced. And most recently, we've just finished a discrete choice experiment. And this was another survey of parents and carers to find out, where do they place medication safety in terms of their priorities for other things that we should be investing in? So, for example, maybe they'd prefer us to spend more resources on improving parking or single rooms, or is it medication safety? Where does that fit? And Virginia's going to be sharing the results of that work with you later today. And finally, we're going to bring a lot of this evidence together to be able to undertake a cost effectiveness study. So I know that's overwhelming, but this is where you can see the results that you'll be hearing about today fits in the overall picture. So finally, what I'd like to do now is share with you some of those first results and answer that question: is eMM associated with a reduction in prescribing errors? So we had our 2 hospitals, children's hospitals, for those of you who don't realise or come from interstate. These 2 hospitals at Westmead and Randwick serve the entire population of New South Wales. And we started the research by a stepped wedge cluster randomised control trial. And some of you might be thinking, what on earth is that? So let me show you what it is. Many of you will be familiar with a randomised control trial. So if a drug trial, we randomise half the group to receive the drug and half the group don't receive the drug, and then we compare whether the outcomes are different. Here, we needed everyone to end up with the intervention, that is the electronic medication management system. So we used a stepped process by which it is rolled out. So we have our wards at the beginning, and in the first step of the study, all the wards used paper medication charts and we collected the error rates. Then the first ward that had been randomised to receive the system implemented the system, and the remaining wards stayed on paper, and this process continued over the entire study until all the wards had the electronic medication management system, and we compare the control period with the intervention period. So one of the incredible things is that the hospital allowed us to randomise the order in which wards would implement the system, which we haven't seen anywhere else in the world has been able to be done, and it allows us to have a much stronger research design. The system was rolled out 1 week apart, and during the trial, over 26,000 orders from children were reviewed. Errors identified were classified according to their potential harm severity by our very experienced pharmacists who were independent from the hospitals. These are the categories. So we looked at procedural errors. We're not going to talk a lot about those today, but that data is available. And then clinical prescribing errors. You'll be familiar, wrong drug, wrong dose, etc. Very detailed definitions for the pharmacists among you. There is an 11-page definition for each of those error categories. We had 3 hospital pharmacists doing this work. They were independent from the hospital, and we also did lots of inter-rater reliability to ensure that they were consistently reviewing the records in the same way and identifying errors in the same way. This is the scale they used to identify potential serious harm. Here we have another lovely child. And as a group, anything over a score of 3, we labelled as serious potential harm. As I mentioned, we also wanted to collect data 1 year after the system had been in place, so we reviewed another 1,000 patient records, nearly another 9,000 orders, and so in total the study had close to 5,000 patients and 35,000 orders from Children's Hospital Westmead. So, did prescribing errors decrease after eMM? Well, during the first 70 days of the system, we saw no significant change in prescribing error rates. And the data is represented here by incident rate ratios. For those of you who may not be familiar, an IRR of 1 means there was no difference between the paper and the system period. And if it's over 1, it means there's an increase, and under 1, there's a decrease. We did, however, see that there was a large increase in errors with serious potential harm. So they increased by 62% during that initial 70-day period. And we also looked at errors associated with high-risk drugs, so things like narcotics and insulin, but we saw no significant change. What happened 12 months later? Well, 12 months later, there was a significant reduction in overall prescribing errors. As you can see here, a 36% reduction. Errors with serious potential for harm returned to the rate that it had been with the paper-based system. But errors associated with high-risk drug orders also significantly declined by 33%. Good news. We were able to look at what types of errors were actually occurring, and there are 4 errors that account for over 90% of all errors in this population. Wrong dose, frequency, route, and duplicate drug therapy errors. We found, as confirmed from other studies, is that wrong dose errors occurred at more than twice the rate of any other of the error categories, so around 7 dose errors per 100 orders. What happened to those specific categories of error over time? Well, in the first 70 days, these 3 categories, wrong dose, wrong route, and duplicate drug therapy errors, all increased in that initial 70 days of use. 1 year later, wrong dose, frequency and route errors had all significantly declined compared to the paper-based system, but duplicate drug therapy errors remained consistently high. And you can see that's represented here in the graph. So what are some of the factors that may have led to some of those increases in that first period of use? Well, this is a sort of overview summary of those 122 interviews that I spoke about earlier. And this is work that was led by Melissa Baisari, who was here with the team at the time. And what we've got down this side is the types of themes and issues that clinicians were speaking about. And you can see across the top when they were starting to talk about some of those issues. So in those first early weeks, weeks 1 and week 3, some of the issues that were particularly raised were the challenges of working with a hybrid system. Some of the wards had paper, some of the wards had computer systems. They talked about inexperience with use, and particularly how they were concerned that that may delay the speed at which they could deliver medications, and that potentially had safety implications. There were some issues that went on no matter how long we did the interviews for. So computers crashing, some of the issues around being able to find a computer, accessibility, and some issues around the usability of the system overall. But as we move along to around 6 months, you can see that people weren't really talking about the hybrid system as much because the system was pretty much throughout the hospital. Inexperience with use, people weren't talking about that. But they did start talking about recognising that they saw that there were some safety benefits. And some of those safety examples came up in those interviews. But we also started to see that was the point at which they started to recognise new errors were occurring in the system that couldn't occur in the paper-based system. And as you can see down the bottom, that's when we started to see workarounds. Clinicians were very good at working out what the system could do, what it couldn't do, and how are we going to get around that to do the work that we need to do. And there's the paper. It's for those of you who like some more detail. So that was our first hospital. We then, as I said, had an opportunity to go to Sydney Children's Hospital, who introduced their system in 2019. So once again, we took a sample of 1,000 kids and reviewed their records before they had the system in place. And then we looked 8 months later at another 1,700 kids' records. And what did we find? Well, we found 8 months after the system had been in place, there was an overall decrease of 16% in overall prescribing errors at the hospital. Errors with serious potential for harm decreased by 33%, and errors in high-risk drug orders decreased by 22%. So, in summary, in terms of answering this question, we can say that both hospitals in the longer term experienced a significant reduction in overall prescribing error rates. We did see this initial increase in the first 70 days of use, and I think there are some lessons that we can learn from that in terms of how can we support that implementation period in terms of training, whether we should go with Big Bang or whether we should go with this rollout system. And later today we're going to have a panel where we're bringing people from around the country who've been involved in the implementation of these systems to talk about some of these factors. And it'd be very interesting to hear your views. One of the important and valuable components of the research, I think, is this comprehensive data we now have about the types of errors which are actually occurring, highlighting particularly dose errors, because it gives us some areas where we need to perhaps target our attention, and certainly with eMM systems where we should be looking for optimisation of those systems. So I know that's been a lot of information, you're going to hear a lot more, but we're really very pleased that we have now been able to deliver this back to you all, and we hope throughout the day that you will be able to share some of your experiences of using the system. Thank you.
Thank you, Johanna. So Johanna's demonstrated a couple of very interesting things there. First of all, that healthcare researchers make very cute children. We've seen a lot of those up there. Secondly, that we really need to measure things to understand what happens, and being old enough to remember the early EMR implementations where we relied on anecdotal evidence rather than real evidence to make decisions. It's fascinating to see real data demonstrating not only the challenges but also a pathway for continuous improvement. We do have some time for questions, so if we have any questions from the audience, do we have a roving mic?
We do.
Well, thank you very much. That was great. And I've got some papers to go and read.
Can I ask you to introduce yourself?
Sorry, Andrew Bell from Darwin. The question I had is, it was really good to see that reduction in error rate over 12 months. How much of that might have been due to the fact that there was a research project happening, and if you didn't have that engagement of your project with the... I mean, it's a hard one to unpack, but I just wonder if you could comment on that.
Sure. Well, I think we can be very confident, I think, that we had pretty limited impact on that because we were retrospectively reviewing prescribing errors. And most of the clinicians, when they were writing their prescriptions, had no idea that we were going to be coming back and looking at it. So I think we can be very confident. I think we also know that it takes probably a lot more than a research project to change clinicians' behaviour, because otherwise quality improvement would be really easy. But yes, so it's a good point, but we can be very confident with the prescribing error data that it is reflective of other things and not just people improving their performance because they were being observed.
I was more interested in what level of engagement you had with the clinicians.
So with the prescribing errors, we didn't have any one-on-one person engagement. We were looking at the records, in the back thing, so they didn't even know that was occurring.
And was there any feedback of results during that 12 months?
So we have certainly, through our steering committee, during the period of the research, we've been feeding back results to the hospital, and that is just an ongoing process for the best way to do that.
Thank you.
I was just curious, in your admissions for drug errors and also in your studies, did you look at disability and psychiatric drugs separately?
So we have information about all the types of drugs and we have them by error category. We haven't finished analysing that yet, so that's something that certainly we could look at. So we've started to look at perhaps some of the most frequently prescribed medications to look at error rates in those, and you'll be hearing this afternoon about errors associated with paracetamol, which is very frequently used. But there are many opportunities, and I think one of the things that we'd like to say is that you now know that we have this large data set of data. We are very keen for it to be used and as much evidence to be drawn from it. So if you have questions that you think would be really important to your practice to answer, please get in touch and we can look at analysing the data to answer some of those questions.
Other questions? If you could introduce yourselves before you ask your question, please.
Hi Joe, Kate Richardson, Northern Beaches Hospital. Thank you for your research over the years because it's certainly helped a lot of us design and improve systems. I'm really keen to understand, can you identify, because I think I understand that at points of the research you would inform back to the sites and they could make changes to their system so that those errors wouldn't occur ongoing. Have you got some good detail about that? Because I think they're the sort of information that the rest of us might be really interested in seeing about design, and I think that's a key point to see the decrease in errors at certain points because of design or improvements in change.
Yep. So certainly one of the things that the Health Innovation Series that we're launching today is about identifying those things, that design features that came out from the research that we feel people should think about looking at in their systems that may be contributing to new errors or could optimise their system. So that's the sort of short answer. A lot of the prescribing error data we were looking retrospectively, so while we were feeding back information to the hospitals, they were then making changes. So this 4-year follow-up is where we might potentially be able to look at, well, these were some of the types of changes we know occur and whether they might influence the 4-year follow-up. It is, as you know, quite challenging to capture all the changes that go on in clinical information systems. I know Michael might have some comments about that, to sort of do this sort of strong matching. And there are all these other potential confounders, and of course then we had COVID thrown into the middle of the mix. So we're trying to untangle some of those things. It's a very good point.
Hello, Johanna. Andrew Matthews from the Department of Health and Aged Care. Look, I know you've covered off some of the things to consider when implementing systems in those early days, but I'm just wondering what you think the medico-legal concerns are now that there's actually some evidence demonstrating there is potential for more harm in those first days. What does that mean medico-legally for project teams and implementation teams who are trying to pitch this to executives, saying, well, what if something goes wrong really badly in that first day? So you're actually saying that there's evidence to demonstrate that there may be increased risk in that initial period.
Well, I am not a medico-legal specialist, so I will defer to other people to think about that. Les might have some comments, having run a children's hospital, about that. I think, a lot of things we do in healthcare are risky and come with risks of implementation, and there are lots of other types of clinical interventions and clinical procedures that have published risk associated with it. So I don't think this is necessarily any different. I think a strength here is that we have the evidence that says, once you deal with some of those initial problems, we know the outcomes overall are better for patients and things are safer. So I think that would be my general response to that. I don't know, Les, if you wanted to comment on that.
It'd be interesting to see whether enhanced training would have helped prevent some of those early errors early on.
Yeah, and I think that raises the issue about, how do you do training? I know the hospital put a lot of effort into just-in-time training, so 2 weeks before. But I think and a lot of it was, they had videos, and I mean, Michael can talk to that in detail. But I think it is always hard to replicate training to what it's like on the ward when everything's happening and patients are coming in and suddenly a system doesn't quite do what you want it to do. So I think that's one of the big challenges. Les?
Liz.
Thank you. Les White, part of the project and on the AIHI board. I don't have anything to add about that specific question, but a related one that may expand it further is there's been several comments and answers around the data feedback and improvements in progress. What about specifically the interviews, given that there was such a wealth of information there? How did that get interpreted and fed back into the system to increase safety and learn along the way?
So obviously publishing the results, talking through the steering committee. We've also talked to, I've done many presentations on it, so, and Mark sharing some of that information. I think it was probably just before the second hospital went live, we did a presentation at the Sydney Children's Hospital to share the experience of what we had seen at the first site. It is always one of the big challenges for researchers working in teams is how many different ways we can try to get information into the system to influence things. And that's why these sort of meetings, bringing people together, but also to think about better ways that we can ensure that this type of evidence gets into clinical information system designs. Because traditionally, there's not a strong tradition of getting evidence and doing research in informatics in this way compared to other discipline areas. So,
I guess it also does demonstrate that challenge of being at the cutting edge, being the first implementation of an eMM in a paediatric setting. And hopefully there's a lot of learnings there that makes the next implementations
better.
No further questions?
Oh, there
One more?
A couple more.
Hi, Kate Callaghan. I'm at St George Hospital here in Sydney. It was interesting, your conclusions about the proportion of error types that were specifically wrong dose and that they were a significant point of concern with the serious harm errors. Did your research team look at subcategorising that any further? Because wrong dose is such a broad category, and the nature of those errors can be, input errors with tenfold things and decimal points versus knowledge errors versus a medication history hasn't been done. Did that analysis come into it at all?
Yes, so we certainly looked at underdoses and overdoses, so a greater proportion of them were overdoses than underdoses. And you're going to be hearing later on today a little bit more about the medication administration and dose errors in that context as well. So yes, there is lots more potential to look at which drugs were involved, etc. We're also going to, when you hear about the harm data, one of the things we did find is that while harm is reasonably low from errors, a high proportion of those where there is harm are associated with dose errors.
One last question. Unfortunately, we are running out of time, but Johanna is
here
here the
all
whole
day.
day, so you can ask her questions all day. But just the last question here from you.
Mel Rose, I'm the Nursing Director for Safe Medication Practice for Tasmanian Statewide Hospital Pharmacy. I'm interested in that sort of first 70-day period that you're talking about, because it's very easy to go to education as the solution, but I'd like to know if you've unpacked the whys around why it got worse before the improvement happened, because I'm really interested in what other strategies might have been useful rather than just expecting it to be all about education, whether change champions or, some mentor system or what it was. Once we know the why, but then we can come up with the solutions. So.
Yeah, I mean, I don't think we have the definitive answer. So we're drawing upon the interviews. It gave us some clues as to what were the things people were talking about were challenging and that might have potential impact on quality and safety. But I think that's one of the reasons we've used this as a topic for the discussion panel later, is to draw on the experience not only of the Children's Hospital in Sydney, but also we've got members from other hospitals in other states, and I imagine that they have a lot to share about their experiences. So I can't definitively answer it, but there are hopefully some strategies and theories that will come out later today.